No, I've only read the other day. Hi.
All right, welcome back everybody, and to Zoomers as well. So we've moved through our Hollywood private hospital specialists, touching on Ramsay Clinic Hollywood with Dr. Chadwick just before lunch. We're now moving into the Glengarry Hospital area. So I'm delighted to welcome to you from Glengarry Gastroenterology, Dr. Ollie Duncan.
Thanks, Wendy, and thanks so much for organising this morning, and I hope you guys have all enjoyed the talks today. So yes, I'm Ollie Duncan. I work at Glengarry, have a practice there, but also work South London and Murdoch and the Understanding Hospital. My talk today will be on functional gastrointestinal disorders. Not quite working.
You can stand back a little bit.
Okay. You got the magic touch. Okay. Yeah, so talking about functional gastrointestinal disorders and management in the primary care setting. So hopefully after a big lunch, hopefully you can stay awake. It's obviously not the most exciting topic, and but one that's so important because we see it so often in primary care, and obviously the gastroenterologist, we tend to see the refractory cases. So the outline of my talk will include a few case studies, just to give you some examples of the common presentations, a bit of perspective on the patient and physician perspectives, talk about the definitions and diagnoses of different functional disorders, epidemiology, pathophysiology, and then the management of the three most common functional gastrointestinal disorders, which are irritable bowel disease, functional dyspepsia, and functional constipation. So a quick quiz just to start off. If we just get you to try and write down your answers on the piece of paper in front of you, and I'll give you the answers at the end of the talk just to see if you've learned anything during the presentation. So the first question is, when assessing a patient with IBS, name 5 red flags that would prompt a referral for a colonoscopy plus minus gastroscopy. Is calprotectin an accurate test for detecting lymphocytic colitis? Name 4 treatments for IBS that have level 1 evidence. So that's RCT evidence or meta-analysis for RCTs. And name 4 treatments for functional dyspepsia that have level 1 evidence. Okay, so just talking, first of all, going through a case study. So this is a patient with irritable bowel syndrome, constipation predominant. This is a 73-year-old female with progressive severe constipation over 50 years with associated pain, bloating, and distension. Her bowels do not open without aperients. She has, but she doesn't have any symptoms to suggest defecation dysfunction. So she doesn't have the sensation in the rectum to open her bowels. She just gets lower abdominal pain and bloating when she feels constipated. She's had multiple ED presentations, and prior therapies include Mobicol, Cloxil, Metamucil, enemas, positries. She's now on a weekly Pico prep regimen with large volume diarrhea and incontinence when she takes this, which is affecting her quality of life, and she can't go out in those days due to risk of incontinence. She's had negative FOBTs. She's never had a complete colonoscopy due to poor preparation. She has 2 first-degree relatives with bowel cancer. So her past history is a common past history that we see in these patients. So history of depression, fibromyalgia, osteoporosis, GORD, hypothyroidism. She's had a surgical history, including a gastric stapling in 1990, which may have had an impact on her gastrointestinal motility, appendicectomy, hysterectomy, and a laminectomy. So she's obviously seen a lot of general physicians during this time. She's been to ED on multiple episodes. And seeing a specialist, I thought probably the best option for her would be a trial of prucalopride. So prucalopride is is TGA approved. It's not on the PBS. Costs approximately $50 a month, but it is helpful in some patients with quite resistant IBS-C or functional constipation. It's prescribed at a dose of 1 milligram, and this is what I started for her for a 2-week period. She tolerated that, and she then increased to 2 milligrams. And since seeing her first in 2020, she's only had 1 hospital admission since. She has 2 to 3 motions per week, and she's only used Pico Prep once in the last 6 months. So, so this is a rare case of someone with long-standing IBS who finds a treatment is actually quite successful. This is certainly not the common story for most patients. The next case study is a patient I saw recently from Christmas Island. So this is a case of refractory IBS mixed. So she's from Christmas Island, 55. She had more than 10 years of symptoms. She has reflux, partially controlled on 20 milligrams of pantoprazole. And she has symptoms of constipation for 3 days, followed by 3 to 4 days of diarrhea, where her bowels will open 5 times in a day, type 7 on the Bristol stool chart with urgency. She's had no PR bleeding, no incontinence, no steatorrhea. She has some hot flushes since her late 40s, abdominal cramping and bloating, and it is impacting her quality of life. And when I asked her, are you here to see me for reassurance or are you here for treatment? She said, I'm here for both. And I think that's an important question to ask these patients, because there's obviously mild IBS where patients are actually not seeking any therapy, they're just seeking reassurance. So she had already been managed with low FODMAP, gluten-free, probiotics with partial improvement. Loperamide caused constipation, which is a common scenario in patients with a mixed pattern of IBS. She denies feeling depressed or anxious, although it has a history of depression and anxiety. Currently well managed, and she's had no loss of weight. Her past medical history includes CLL, GORD, IBS, polycystic in her 20s. She's on cloxin, PRN, pantoprazole, and irbesartan. She is a smoker. She drinks 14 standard drinks per week. She's been quite thoroughly investigated already. So she's had a normal ultrasound, normal bloods. Her celiac serology was negative. Her gastroscopy and colonoscopy were normal, including duodenal and colonic biopsies, and that was in 2019. So within 5 years, and if they've had a colonoscopy within 5 years, then that is very reassuring for any significant pathology. It'd be a rare case that someone will have a cancer that's been missed. So the management for her is, first of all, reassurance, spending time talking about the diagnosis. recognizing that it is affecting her quality of life and validating her symptoms, and then trying to target treatment towards her symptoms. And that's probably the key in these patients. So not offering them like every possible treatment known to IBS sufferers, but trying to target whatever their problem is. So if it's pain, focusing on pain, it's bloating. And when administering any treatment advice, do it sequentially. So give them a month of treatment, see if it improves. Otherwise, it gets very confusing for patients. It's also important to recognise that for many patients who won't be able to cure their problem, particularly a patient who's been refractory for 10 years in this scenario, and it's worth mentioning that to patients that there is no cure, but we can improve your symptoms, improve your quality of life, and just show that you're there with them and here to help them through it. So the plan for her was just a stool PCR, just to be sure there's no infection like Giardia we're missing. Repeat her blood test to make sure she's not newly iron deficient or there's other red flags. And then in a sequential manner for her, Metamucil, cholestyramine for possible bile salt malabsorption. She's had a cholecystectomy in the past. Increase with pantoprazole to 40 milligrams to control the reflux, but then with a definite plan to try and dose reduce in the future, and then consider NDEP down the track. But most patients actually resistant to this idea. So a quick mention of the patient perspective. So there's quite a few articles written by patients talking about their experience with IBS. And there is stigma associated with the diagnosis. Even the word functional has a stigma associated with it. And there is actually a move by the Rome Foundation, who created all the documents around diagnosis for IBS, to move away from functional gastrointestinal disorders as the name of the condition, and move towards disorders of gut-brain axis. The lack of organic features can lead physicians to review the disorders of little importance, and can attach negative attitudes towards the patient. And the attitude can be damaging to the patient. And patients fear being seen as having a psychological disorder, and the majority of patients don't even tell their family and friends that they have the condition due to fear of stigma. From a physician perspective, so just a little experiment from my side. So who here has had experience treating IBS? So just keep your hands up. Who feels comfortable treating IBS? Yeah, and so most people put their hands down, and put your hands up if you enjoy treating IBS. So here's the expert. Yeah, so a lot of people feel frustrated because the treatments don't work. That's probably the reason. It's not easily cured, it leads to physician burnout. But physicians, we have to know how to make a diagnosis. We have to help these patients. They come see us regularly. And we need to be confident in making a diagnosis, and then also excluding organic pathology, but not over-investigating and making patients feel more anxious about their condition. Once a diagnosis is made, communication with the patient is key. So refrain from saying, "We think you have IBS." Phrase the diagnosis as "you have IBS." Try to subclassify it as diarrhea predominant, constipation predominant, or mixed. Clear and concise education to be provided. Empower patients to ask questions. Ask about quality of life, and validate their experiences. And talk about function as well. Is it impairing their function? So I won't go through all of these different disorders, but essentially the Rome criteria is developed by the Rome Foundation. They're up to the 4th version of the criteria, and it groups the disorders into esophageal, gastroduodenal, bowel disorders, centrally mediated disorders of gastrointestinal pain, gallbladder and sphincter of Oddi disorders, and anorectal disorders. We won't run through the definitions of all of them. That criteria is mainly used in the research setting. It's useful for epidemiological studies, but it's not particularly useful in the clinic. I'll just quickly talk about some of the more common disorders. So functional dysphagia, so this is a sensation of abnormal food bolus transit through the esophagus in the absence of structural, motor, or mucosal abnormalities. To truly make the diagnosis, you need to do a gastroscopy, biopsy the esophagus for eosinophilic esophagitis, and then also do a barium swallow and high-resolution esophageal manometry. But obviously, the majority of these patients don't have those tests. If it's mild or if it settles, then we don't tend to do the manometry. But the prevalence in that is around 3.2%. Functional dyspepsia, defined by one or more symptoms, including postprandial fullness, early satiety, epigastric pain, or epigastric burning. And again, most people with dyspepsia, once they've failed a trial of PPI, will end up having a gastroscopy, particularly if they're over the age of 55, along with an ultrasound and routine blood tests. And in functional constipation, it's very common, 11.7%. And these are patients who basically have constipation, but they don't have the other dominant symptoms of IBS, which include pain and bloating. They can have those symptoms, but it's not a dominant factor. Irritable bowel syndrome. So this is defined by recurrent abdominal pain at least 1 day per week associated with defecation or a change in bowel habits. Prevalence around 4.1%, but it's actually probably higher. There's a lot of crossover between the disorders, including functional diarrhea, functional abdominal bloating and distension. Probably more like around 10% of the population. This is the largest epidemiological study worldwide. It was a study published in 2020. They did an internet survey across multiple countries, as well as household surveys in countries where internet was not easily accessible. And you can see there's quite a difference in the prevalence rates comparing the internet and the household surveys. And it might be partly explained by the household surveys were done in countries or third world countries where there's difference in diet, genetics, as well as potential social reporting of the condition. But the main take-home point here is it is common, and it's more common in females, both on the internet and the household survey, which is seen across multiple epidemiological studies. In Australia, you're looking around 30 to 40% of patients with a functional gastrointestinal disorder. And the natural history is actually quite well documented. So they're chronic conditions. The symptoms fluctuate. 2 and more functional gastrointestinal disorders often coexist. 1/3 of patients will end up having unnecessary surgery, so cholecystectomy, hysterectomy, or appendicectomy. 40% take medications for their symptoms, but there is a reduced health-related quality of life. There's high absenteeism, but there's no impact on mortality, and that's why there's not a lot of funding for research, and the research in the area is actually generally pretty poor. And there's also therefore not many clinics or public health strategies in place to manage these conditions, and it really is just left to general practice to manage. This is probably one of the best natural history studies for IBS. So it was an American study that followed 1,300 patients between 1988 and 2003. And it looked at point prevalence. So they did have some additional patients that came onto the study later on. And there was no change in the point prevalence between that period of time. What it did demonstrate that 40% will have no symptoms after 15 years, 20% will have the same symptoms, and then 40% will have different symptoms. So this is good. You can tell patients with a new diagnosis that there is a possibility that their symptoms will just go away and at 10 to 15 years for reasons that we don't understand. As you can see here with the IBS, any 55% have complete disappearance of their symptoms after this 15-year follow-up study. So have there been any advances in the understanding of the pathogenesis of IBS or functional gut disorders? So by definition, there's no structural abnormality to explain functional gastrointestinal disorders. And in the past, the pathogenesis has been attributed to visceral hypersensitivity, abnormal motility, and psychological disturbances. So the gut-brain axis. But more recently, there's some evidence to show that in a certain subset of patients, low-grade intestinal inflammation, increased intestinal permeability, immune activation, and disturbances of microbiome play a role in particular subsets of people. get there eventually. Doesn't want to go to that page. Yeah. Really need this picture to demonstrate what I'm doing. There we go. Okay. So there's a new proposed gut-brain intestinal disease model. And just to make the point, this hasn't impacted clinical care at all at this stage. So it's just preclinical. There are studies now showing that in patients with IBS, if you biopsy their bowel, there is a certain patient group will have increased numbers of mast cells, T cells, and there's a high number of gut-specific T cells in the peripheral blood. The same with functional dyspepsia, increased eosinophils in the duodenum, and increased gut-specific T cells in the blood. So there, in a certain group of patients, there probably is an inflammatory component contributing to their disorder. And the proposal is that you have a gut antigen, whether it be the microbiome, something in the microbiome, or food peptide, that triggers T cell activation, which then drives the recruitment of B cells, and the recruitment of mast cells, and antigen-presenting cells, dendritic cells, trigger the activation of T helper 17 cells, which release cytokines, which drives eosinophil and mast cell degradation, and then those cytokines activate the nervous system, the enteric nervous system, causing change in visceral sensitivity as well as visceral hypermobility. And then this further cytokine environment causes an alteration in the intestinal barrier, which can affect tight junctions, release of cytokines, and then those cytokines might drive the impact on anxiety in the gut-brain axis. So this is very early studies, but there is thought to be, in certain patients, this inflammatory component to the condition. Obviously, there are people who have more stress anxiety that drives the underlying pathogenesis. And you can often gauge this in the history taking when you see these patients. And then in functional dyspepsia, it's thought that that there are studies showing that there's reduced clearance of acid from the duodenum that results in reduced accommodation of the fundus, which can impact the distension in the antrum, which then results in increased distension and pain in patients with functional dyspepsia. So there likely is to be there's obviously different types of IBS that are not classified from a pathological point of view that we're unable to identify in clinical practice, who eventually we may be able to subclassify and target treat towards in the future. So just talking about it, moving on to one of the more common functional gastrointestinal disorders, so irritable bowel disease. So we went through the diagnosis before, but the warning signs to think about referring for further tests include being age over 50, so development symptoms over the age of 50, and no previous colonoscopy within 5 years, melena or hematochezia, nocturnal pain or nocturnal bowel motions, unintentional weight loss, family history of colorectal cancer or IBD, a palpable mass, obviously, iron deficiency, and a raised CRP. So what is the diagnostic algorithm for IBS? So obviously you first take a history. You take a history. If there's no red flags, so if there are red flags in the history of examination, then you refer for bloods, ultrasound, gastroscopy, and colonoscopy. If there are no red flags, you still do bloods, including serology. If they have diarrhea predominant IBS, then a calprotectin, which is now rebatable on Medicare, and a multiplex PCR to exclude infection, and an ultrasound of the abdomen and pelvis if the patient's a young female. If all normal, then the positive diagnosis for IBS is made, and then initiate treatment based on the predominant symptom. So what is the role of calprotectin? And it is recommended by the American Gastroenterology Association, along with CRP in terms of excluding inflammatory bowel disease as a cause for their gastrointestinal symptoms. There's a meta-analysis that shows a sensitivity of 0.93 and a specificity of 0.96 for excluding inflammatory bowel disease, so Crohn's disease and ulcerative colitis. Not quite as good in children and teenagers, and it's thought that the specificity drops off because the effect of collecting a stool through the nappy results in a change in the concentration of calprotectin. It's not useful in microscopic colitis, and that's why particularly women who are over 50 who present with diarrhea really will end up needing a colonoscopy because calprotectin is often normal in that scenario. And calprotectin is a protein that's released by neutrophils, not by lymphocytes. And lymphocytic microscopic colitis is driven by lymphocytes, not neutrophils. So that is the one caveat to remember about calprotectin. It is not good in the setting of microscopic colitis. Excluding endometriosis, so 98.9% of surgically diagnosed endometriosis experience bowel symptoms, and often it's gynecologic specialists they see first, and we can often delay their diagnosis. So we need to think about it. They should have a transvaginal ultrasound to exclude endometrioma, and a referral to a gynecologist in young women with no organic GI cause and with refractory symptoms. So what are the risk factors for IBS? So previous acute enteric infection, and there is this subclassification of IBS, which is post-infectious IBS, female sex, younger age, and other functional somatic syndromes such as fibromyalgia and chronic fatigue. The patients who tend to do worse are the patients who are resistant to treatment, are patients with underlying anxiety, depression, poor coping skills, coexisting conditions such as fibromyalgia. They tend to do worse compared to others. So what treatment do we have for irritable bowel syndrome? So there are lots of meta-analyses and randomized controlled trials showing benefit in IBS. It's actually quite impressive that a drug actually shows benefit in IBS because it is a mix of different, probably different diseases and different causes for their underlying symptoms. So it's very impressive that they actually can show a benefit, I think, in a clinical trial. So psyllium does improve IBS symptoms. So this randomized controlled trial of 275 patients compared psyllium to bran to placebo, and there was a improvement in symptoms at 3 months, so 46% versus 32% for placebo. And the placebo effect is always really high in IBS, but all the benefit was seen in improvement in the consistency of their stool. So their increased regularity of stools, reduced diarrhea, but no improvement in abdominal pain and no improvement in quality of life. So the low FODMAP diet, so you all know the low FODMAP diet, it's used commonly. There's a diet focusing on fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. The pivotal trial, which is a Melbourne trial, which is on the left there, showed a 20% difference in symptoms in patients randomized to the low FODMAP diet. So it is an effective diet. And it was confirmed on a US trial showing patients who are on the low FODMAP had significant improvement in pain compared to patients on the modified NICE diet. The problem with the low FODMAP, it is very intense. It can have a social impact because it really is a quite exclusionary diet. And it's certainly not my first line treatment for patients with IBS, because I think certainly certain patients with IBS can get very stuck on the diet, become quite obsessed with the diet, and I think in that can actually impact their quality of life as well. So in general, I ask patients about their diet. What does their diet consist of? A lot of high FODMAP foods, and then give them some education about reducing some of those FODMAPs. A lot of patients come to you saying they're on a gluten-free diet. In fact, most patients have been on a gluten-free diet before they even come to see you. So there is a good trial. This is a randomized controlled trial here that randomized patients who are on a gluten-free diet with a diagnosis of IBS, celiac disease have been excluded, and then they put them onto either a gluten-free diet or placebo. And you can see 68% of symptoms were not adequately controlled versus 40% placebo after a 6-week period. So suggesting that there is impact of gluten on symptoms. The problem is gluten containing foods are also high in FODMAPs. So this particular study put people on a low FODMAP diet and then introduced gluten versus placebo, and they showed no difference in symptoms with gluten on top of the low FODMAP diet. So the improvement on gluten may actually be the reduction in the high FODMAP foods. As physicians, we quite often refer patients for a colonoscopy to reassure them about their symptoms and to show that there's no adverse conditions. I think we're actually reassuring ourselves. So this is quite a nice study, and it's very old now, 2005. It showed that colonoscopy does not improve patients' patients' quality of life in IBS. So it doesn't reduce their anxiety and it doesn't reassure them. So what this study did was they looked at patients retrospectively with a diagnosis for IBS, and they looked if they'd had a colonoscopy within 12 months or even more than 12 months ago, compared to those who had not had a colonoscopy, and there's no reduction in mental health related quality of life, physical health related quality of life, and also no impact on reassurance. So they asked the patient, do you think something serious is wrong with your body? And that had no impact between the groups. So we tend to reassure ourselves rather than reassuring the patients. Antispasmodics, peppermint oil and loperamide. So they all do have some evidence for working. So as antispasmodics such as buscopan, so 23 trials, over 2,000 patients, risk reduction of 0.69 with number needed to treat of 5. Mebeverine is in that group, but there's actually not a randomized controlled trial showing convincing evidence. Peppermint oil is superior to placebo, so number of trials 5, number of patients 400, number needed to treat is 3. Loperamide is an effective antidiarrheal, but has no impact on any other symptoms of IBS, and particularly with mixed IBS, they can get more constipated and their symptoms can actually deteriorate. Now, ondansetron has actually been studied in IBS as well, obviously not indicated in Australia for this use. You would have noticed a lot of people on ondansetron do get constipated, and so it is an effective treatment in IBS-D with an improvement in the Bristol stool form, as well as reduction in their urgency and even actually reduction in their bloating. And this was confirmed with a slower transit time. Antibiotics and probiotics. So most people have tried probiotics, and some people do report significant benefit. And there are a lot of randomized controlled trials showing benefit. So 23 trials, 2,000 patients, number needed to treat of 7. So not everyone will get benefit. There's no guidance on the composition of the particular probiotic used, or even the colony forming units. So you can just tell the patient to just go to the pharmacy and buy any old probiotic. Now, rifaximin, which is approved for use for hepatic encephalopathy in Australia, but not for IBS, is effective in IBS-D, demonstrating there is obviously a microbiome component contributing to patients' symptoms. And there's 5 really good randomized clinical trials showing benefit with a number needed to treat of 9, with improvement in diarrhea and in particular bloating. And bloating is a very difficult symptom to treat. And in refractory symptoms, I certainly will occasionally use antibiotics, rifaximin if they're willing to pay for it. This trial used 2 weeks of treatment, 550 milligrams TDS, and showed benefit of 3 months in symptoms. And this probably suggests that there is some overlay with small intestinal bowel overgrowth. These trials did not do any lactose breath test to exclude SIBO, which is a very poor test anyway. But there's clearly overlap between the conditions. Antidepressants. So there's also a lot of evidence for use of antidepressants, so mainly tricyclics. So number needed to treat of 7. SSRIs, number needed to treat of 4, and there's improved global symptoms and pain relief. Unfortunately, 31% will have adverse effects, and that's because tricyclics are commonly used, and there's poor patient and physician acceptability, which often limits use because people are not keen to go on an antidepressant in the absence of anxiety or depression. Psychological therapy. So there's also evidence to show that CBT, hypnotherapy, does provide benefit, but the trials are fairly poor, and only 4 trials use a sham or controlled psychological intervention. And there are also online services available, and this particular service out of Melbourne called the Gut Centre I do refer to, because they have a focus on gut health, and they do use CBT and also hypnotherapy. So I can't do a gastroenterology talk without talking about fecal microbiota transplant. So there are actually 2 randomized trials showing benefit in IBS. There's one trial that showed no benefit, and the benefit was seen in response to symptoms, no improvement in quality of life. But this particular trial out of Europe randomized people to 2 different doses of FMT. The donor was a super donor. He was highly educated, had the perfect diet, exercised 3 days a week. This was all in the trial, documented. And he had a perfect microbiome, so no dysbiosis. And his feces were given randomly to the 3 patient groups, delivered through a gastroscopy, so duodenal insertion. And as you can see, there's quite a significant difference in response of symptoms. But interestingly, there was no significant difference in the level of dysbiosis between the placebo and the FMT groups, but there was a change in the microbiota composition of their stool. So moving on to chronic idiopathic constipation. So I won't run through all of this, but the main thing is obviously any alarm features you refer for colonoscopy and bloods, and also check their calcium and thyroid function. Stop any offending medications. If there's no improvement, then you first of all go to fibre. That can worsen some people with constipation. If that does, then ask them to stop it. But the first choice would be Movicol. And if there's no improvement after that, then you're looking at other techniques, like either using high dose laxatives on an intermittent basis using Pico Prep, suppositories, enemas, or potentially prucalopride, but also focusing on whether or not they've got slow transit constipation versus defecation dysfunction. If they've got defecation dysfunction at that point, then you should be referring them on to a women's health physio. And there's lots of evidence for all of the laxatives in providing benefit in the constipation. The prucalopride trial that I mentioned, there's quite a few, about 3 randomized controlled trials looking at the use of this drug. So the outcome was going from the percentage of patients would have more than 3 spontaneous bowel motions per week. And in men, you're looking at 31% versus 16% for placebo, 26% for women versus 12.1% for placebo. So a reasonable response for quite often refractory constipation. The last functional gastrointestinal disorder I'll talk about is the management of dyspepsia. So again, this algorithm doesn't actually include blood and ultrasound. I think all of us would order blood and ultrasound for someone presenting with upper abdominal pain. Dyspepsia is described as upper abdominal pain or early satiety or distress postprandially that lasts for at least several times per week for 3 months over a 6-month period. And with patients who are under the age of 55, then you can just test non-invasively for Helicobacter pylori. If it's positive, you treat. If it's negative, then you trial PPI. If they're not responding to PPI, then I'd refer them for a gastroscopy. And if that's negative, then you're looking at either a prokinetic or a antidepressant such as NDEP. If they're over 55, then they should be referred for a gastroscopy and biopsies taken with Helicobacter pylori and treated. And then if that's positive, then if it's negative, then going down the PPI route again. And what is the red flags we need to be worried about? So new onset dyspepsia over the age of 55, evidence of gastrointestinal bleeding, dysphagia, vomiting, unintentional weight loss, family history of gastric or esophageal cancer, palpable mass, and then iron deficiency after blood testing. So what is the evidence for therapy? So Helicobacter pylori does improve symptoms with a number needed to treat of 15. Proton pump inhibitors also improve symptoms, number needed to treat of 10. And so do H2 receptor antagonists, Prokinetics such as domperidone don't have convincing evidence for use in functional dyspepsia, and antidepressants do. So there's a randomized trial of 292 patients referred to, randomized to NDEP at 50 milligrams versus escitalopram 10 milligrams versus placebo, and NDEP was better than SSRIs. So for functional dyspepsia, tricyclic antidepressants is the first choice of treatment, unless, of course, you feel there's a significant underlying anxiety or depression driving their symptoms. So just the final summary of my approach to functional gastrointestinal disorders. So they're common and they impact the quality of life. So you do need to take them seriously and validate patients' symptoms. Assess for red flags and decide on the need for non-invasive versus invasive investigations up front. Once organic pathology is excluded, make a diagnosis and reassure the patient. Assess severity and impact on quality of life. If mild, give them the option of no treatment, because as you can see, a lot of the treatments don't work and can be expensive and can also create additional anxiety around their condition. Subclassify functional gastrointestinal disorders and target treatment before symptoms. So, for example, if it's constipation, predominant focus on the constipation, use psyllium as a first-line treatment. If it's diarrhea predominant, then you're looking at, is there a significant pain component, or is it mainly diarrhea? If it's diarrhea, then use loperamide. If there is pain and bloating, then you're looking at using dietary advice, so lactose-free, low FODMAP, gluten-free, peppermint tablets. You might end up trying the psyllium husk. And then in patients who are still resistant, going down the route of using NDEP. Now, mixed is much more difficult to manage, but often a trial of psyllium is a good approach to start off with. And then using other treatments to assist with their bloating and pain. So whether it be peppermint oil for their bloating, which is given at a dose of 1 tablet 3 times a day, or look at treating the pain component by using NDEP. So refer for red flags if there's positive non-invasive tests or refractory symptoms. So just back to those quiz questions. So if you just want to see if you got them all right, which I'm sure you all did. So when assessing a patient with IBS, name 5 red flags that would prompt a referral for gastroscopy or colonoscopy. So age greater than 50, PR bleeding, unintentional weight loss, family history of colorectal cancer, iron deficiency, nocturnal symptoms, or elevated CRP. Is calprotectin an accurate test for detecting lymphocytic colitis? So no, hence the reason for colonoscopy with new onset diarrhea over the age of 50. And name 4 treatments for IBS that have level 1 evidence. So psyllium, low FODMAP, peppermint oil, ondansetron probiotics, on amitriptyline and SSRI. And then name 4 treatments for functional dyspepsia that have level 1 evidence: PPI, H. pylori treatment, H2 blocker, and amitriptyline. So thank you very much, everyone, and hopefully that's been useful. Any questions?
You mentioned when the treatment with Heliobacter, you said the number to treat was 9.
Yes.
Is that in a setting of standard dyspepsia, when you would normally expect a much higher response, or in part of just irritable bowel?
Yeah, it's a good question. I didn't actually go, because I thought about that, because obviously, but the number need to treat for even Helicobacter in the absence of functional chronic dyspepsia is still not that good either. So you don't expect much better number needed to treat. So by definition, really, with the diagnosis of functional dyspepsia, you shouldn't have Helicobacter, because there shouldn't be an organic pathology driving the diagnosis. So so in reality, we're really just dealing with patients who have a diagnosis of Helicobacter, and that's the number needed to treat. So if they get better, then it really isn't functional dyspepsia, is it? Because you've taken away that organic pathology and they have improved.
Another question about that. In the fecal calopectin test,
Yes.
I gather there's an age limit on what you can claim.
Yeah, so it's 50, so the age of 50. So
What's that?
because of the red flag, so the fact is that if you've got new onset diarrhea and you're over 50, then that really is a red flag, and you should be having a colonoscopy. Now, if you are someone who's already had a colonoscopy within the last 5 years and you want to exclude new onset ulcerative colitis or Crohn's disease, then I think it is a good test. It costs approximately $80 for the patient. And I think it's a good test rather than going for colonoscopy in that scenario. So the reason is it shouldn't be used for that reason. And maybe it is also a cost issue for the government.
Ollie, we've had one question come in from one of our Zoom participants. So
the treatment for lymphocytic colitis, is it just symptom control if diarrhea? So lymphocytic colitis is a very benign condition in terms of it is not a risk factor for colorectal cancer. It doesn't turn into ulcerative colitis or Crohn's disease, but it does have a big impact on people's quality of life. It's a really useful diagnosis to make because you will just change their lives completely when you prescribe budesonide. So budesonide has an amazing response in this condition. It's again, like a lot of autoimmune conditions, it fluctuates. So you can give them 3 months of treatment with budesonide, and then you might push them into remission for a year or so. And it may never come back, but for many people it does return, and then often they do need low-level budesonide to control their symptoms. So, but to answer the question, if they don't have diarrhea, we've got the diagnosis, then no treatment is required. If you can control it with gastrostop, then that's also adequate to control the condition. So you don't have to prescribe budesonide. As you know, budesonide is not on the PBS for that indication, so it does cost a fair bit of money, but the price has recently come down. So I think it's $50 for 90 tablets. Previously, it was $180, and you do get a rebate. Patients with private health insurance, HBF, do get a rebate with budesonide.
Sorry.
You mentioned with constipation that it's important to differentiate between slow transit and defecation dysfunction. How do you actually differentiate that from them?
So it really is based on history. So it's more common to find slow transit constipation. So it's pretty unusual to find defecation dysfunction. But the question you need to ask is, do you get the sensation around the rectal region to go to the toilet and you can't open your bowels? And that's the red flag for defecation dysfunction, versus people who are constipated and get low abdominal pain and bloating. You can do slow transit studies. There's also studies including MRI proctograms, but these are for really resistant patients and not commonly used.
Okay, I've got 2 questions. One is, if the patient has the resistant Helicobacter, treatment, not responding with a couple of eradication treatment, and what's the other antibiotics you go to? What is the other approach? Second question is, you did mention about the fecal protein eligibility. Is it, I'm not clear, is that under 50 is eligible or above 50 is eligible?
Yes, so under 50 eligible. You need to have diarrhea. You have to exclude an infection, so send a stool PCR off, and then have no red flag symptoms. And
above 50 with the colitis symptoms, they are not eligible, or
so they're not eligible. It costs $80, but most patients are willing to pay for it because they'd rather do that than having another colonoscopy. Yeah.
Or the resistant.
Great question. Yeah, so I routinely just go first line for moxifloxacin-based treatment. It's not on the PBS again. It costs patients $80, and I combine that with amoxicillin plus PPI. So levofloxacin is actually on the TGA therapeutic guidelines, but it's not available easily in Australia. So I just use moxifloxacin in place, and you have a 90% success rate for that regimen.
Thank you.
And if they're still failing treatment, then they should have a gastroscopy biopsy and send for culture and sensitivities.
Thank you.
Okay, so we're running a little over
Okay.
time. We do have one last question we're going to throw at you from Zoom, which is your thoughts on leaky gut syndrome.
Okay, that's a tricky one to finish with.
Yes.
So I suppose this is referring to alteration in the gut junction between cells, and that's what I mentioned on the pathogenesis side. There probably is a subgroup of patients where there's an inflammatory driver that affects the intestinal barrier, resulting in increased cytokine release that travels through the portal circulation, has all kinds of effects on, for example, liver inflammation, potentially depression, anxiety. But at this stage, it still has no clinical implications because we have no way of testing for it.